Hello everyone, this is Dr. Naz and today I'll be discussing about pneumothorax. It refers to the air in the pleural cavity. The patient will present with sudden onset of shortness of breath, pleuritic chest pain. There will be tympanic note on percussion and the breath sounds on the affected sides will be absent. So there are two causes of spontaneous pneumothorax. It's primary, which is the most common cause, and it is idiopathic. It happens in young, tall, lean male individuals, and the other is secondary, which is due to any coexisting disease. There are so many causes of secondary pneumothorax like emphysema, cystic fibrosis, severe asthma, tuberculosis, sarcoidosis, Marfan syndrome, Ehlers-Danlos syndrome, lung cancer, etc. So spontaneous pneumothorax occurs when there is a rupture of a subpleural valve which produces a hole in the pleura, the loss of negative intrathoracic pressure, and there will be lung collapse. Trachea deviates to the side of the lung collapse. This is a spontaneous pneumothorax showing in the chest x-ray. On the left side there is loss of bronchopulmonary markings. You can clearly see bronchopulmonary markings on the right side, whereas in the left side there is no bronchopulmonary marking, as well as it is a jet black shadow, and this is you can also appreciate a collapsed lung border. So the management depends on if it's primary or secondary. So if the causes are known and the pneumothorax is more than 2 cm, you will do needle aspiration, and if it's less than 2 cm and the patient is asymptomatic, then you will discharge the patient safely. For secondary pneumothorax, that is the patient is having a disease already, example emphysema, tuberculosis, COPD, cystic fibrosis, Marfan syndrome, all the other causes which I have already discussed. If with these causes there is more than 2 cm of pneumothorax, then you will insert a chest tube, and if it's 1 to 2 cm, then needle aspiration will be enough, and if it's less than 1 cm, then you have to keep the patient on high flow oxygen. So the causes of tension pneumothorax are penetrating chest wall injuries, iatrogenic, or positive pressure ventilation. So the flap-like pleural tear allows air into the pleural cavity but prevents its exits because the flap is a one-way flap, and it increases the pressure in the pleural cavity. The trachea deviates to the contralateral side of the pneumothorax in tension pneumothorax. So this is the picture of tension pneumothorax. You can clearly appreciate that the trachea is deviating towards the unaffected lung. Immediate needle decompression is needed by inserting a large bore, either 14 or 16 gauge needle, into the second intercostal space in the mid-clavicular line. There will be immediate rush of air which will convert tension pneumothorax into a spontaneous one. Then you can go for a definitive treatment, which is chest tube insertion at 5th intercostal space, mid-axillary line. So that's it. I hope you learned something from this video. If you do, please like and share it and subscribe to my YouTube channel so that I get motivation to make further videos. Thank you so much for watching.